My topic is ASA Task Force Recommendations for Perioperative Blindness. Perioperative visual loss is a rare but serious complication. Its incidence is 1 in 65,000 to 1 in 1,25,000. The main causes are ischemic optic neuropathy, which is divided into anterior and posterior. Anterior is most common in cardiac surgeries. Posterior is common in spine surgeries. The second one is retinal arterial occlusion. It can be a complete central retinal arterial occlusion or a branched retinal arterial occlusion. Other causes includes cortical blindness, which is an ischemic event in the visual cortex of the brain, which is common in pediatric age group, that is less than 18 years. Other causes include acute glaucoma, choroid or vitreous hemorrhage. Spine surgeries, cardiac surgeries, head and neck surgeries have a higher incidence of postoperative visual loss. The mechanism mainly include external compression of the eye, which is mainly seen in the prone position, decreased arterial supply, either by an embolism, mainly seen in cardiac surgery, or decreased systemic blood flow, impaired venous drainage, thrombosis from a coagulation disorder. The main clinical features will be the painless visual loss associated with abnormal pupillary activity, with chemosis, proptosis, ptosis, corneal abrasion, ecchymosis, etc. Coming to the risk factors, it includes patient factors, which includes male, sex, obesity, diabetes, hypertension, atherosclerosis, tobacco use. Surgical factors include prolonged anesthesia time, significant blood loss, and using some frames for the positioning spine patients like Wilson frame. Anesthetic factors include intraoperative or hypotension, hemodilution from using a large amount of crystalloids for resuscitations, and use of vasopressors. Coming to task for recommendation, preoperatively, we should identify the high-risk patients and should get an informed high-risk consent. If the surgery is a prolonged surgery, we can plan as a stage procedure to reduce the anesthesia time as well as to reduce the blood loss. These patients undergoing for a long spine surgeries or long duration surgeries, the patient can be given some idea about the possible complication of visual loss preoperatively. The intraoperative managements include positioning of the head, maintain the head at or above the heart level in a neutral forward position. We can avoid using the horseshoe pillow as well as the square pillows. It has to be a foam filled pillows. We have to reduce the pressure over the eyes and avoid eye compression, like utilizing a headrest that avoid direct pressure on the eye, checking eye position periodically every 20 minutes visually or by manually by keeping a mirror under the pillows. 3-pin skull clamp can be used in the cervical spine procedures, which can eliminate this eye pressure. Maintaining the hemodynamics, like continuously we have to monitor the blood pressure in high-risk patients and avoiding prolonged hypotension. Managing with a proper fluid resuscitation, like using colloids as well as crystalloids for the significant blood loss to maintain intravascular volume. Monitoring hematocrit by checking hemoglobin in a high-risk patient with significant blood loss. Post-operative recommendations mainly include yearly assessment, like when the patient is alert, we have to evaluate the vision of the patient, and if there is the patient complains of any visual loss or any issues, we have to get an urgent consultation. If visual loss is suspected, urgent ophthalmologist consultation is must. We have to optimize oxygenation, hydration, hemodynamics. For ischemic optic neuropathy, we can elevate the head end of the bed and correct the volume depletion and maintaining or increasing the arterial pressure. Acetazolamide, mannitol, furosemide, steroids and hyperbaric oxygen can be given as a treatment. For retinal arterial occlusion, systemic thrombolysis can be attempted if there is no contraindicated. Ocular massage and acetazolamide can be given. However, in task force, it has no evidence for supporting the use of steroids, antiplatelets agents, intraocular pressure lowering agents for perioperative visual loss. Thank you, sir.
We mentioned only three conditions for visual loss. One is spine surgery, cardiac surgery, and head and neck surgery. Are there any
Yes,
other surgeries where visual loss can happen?
for TURP procedures, there would be
So visual
twice.
loss means you have to mention visual loss which can occur as a permanent loss as well as a temporary loss. Okay? And apart from that, any other surgery which can also result in a temporary loss of vision in the eye itself, ophthalmic surgery,
Ophthalmic, glaucoma,
retinal surgery.
retina.
Okay? When they do retinal surgery, they introduce an air bubble to keep the retina without collapsing again. That also can cause a temporary visual loss. And so all these things have to be mentioned in addition to that, even though they are reversible. Sometimes this visual loss which happens after spine surgery or cardiac surgery can be irreversible also. That is the reason why they do this question. And majority of the times we can anticipate who are the patients who are likely to develop this particular problem. But, sometimes it can suddenly occur as a surprise in patients, but the main aim is to position the patient properly so that we can heterogeneically avoid this particular problem. What is the role of intraoperative hypotension, induced hypotension, which is asked by the surgeon for spine surgeries? Does it have any bearing on the visual loss?
Yes, sir. The systemic blood flow will be decreased, sir. So cerebral blood flow will be decreased, and the blood flow to the arteries to the optic nerve will be decreased, sir.
But
The perfusion will be less.
But we do practice, isn't it? All of you, as a NEOT student, you know that spine surgeons ask for reduction in systemic blood pressure, and you use NTG or other agents to keep the blood pressure low. So sometimes that also happens. But studies have proved that induced hypotension does not have a direct proportion to the visual loss. Okay? So if the surgeon wants, you can discuss the possibilities, and if the patient has features where like atherosclerosis or comorbidities like diabetes and all those things, then you can think of avoiding induced hypotension in those patients. Otherwise, induced hypotension has been safely practiced without resulting in perioperative visual loss in many patients. Okay? So I'll just show you